Just a little bit of a background. We work for DeciBio. We're a strategy consulting firm specifically focused in precision medicine right down the road in Century City. And precision medicine really means a lot of different things in a lot of different industries, ranging from immunotherapies, ranging from diagnostics, and also the software that ultimately supports it. And so we work with customers that work in this space. And so immunotherapy is really one of the big areas that we actually do spend a lot of time in, just because there are a lot of different precision ways of targeting the immune system and basically treating cancer, and something that is a little bit more cutting edge than some of the tools that have previously existed. So, and I also just want to quickly say thank you so much for CSCLA for inviting us to speak here today. We really appreciate this opportunity. And thank you all for coming out today and listening to us. So just to quickly touch base on this, this has been medically reviewed by a professional earlier this year. There are several disclosures from CSCLA just regarding funding as well as oversight of today's session. And we have also personally worked with a number of different experts in this field and also developers in the immuno-oncology space, including BMS and on consulting bases. So really just to give a quick overview of what we're going to be covering today. We got the introductions out of the way, but we'll start by going into what is immunotherapy. Is immunotherapy right for me? What you should know about clinical trials. A quick overview of some of the possible side effects associated with immunotherapy. And then, depending on time, going a little bit into types of immunotherapy, quality of life, and potentially the future of immunotherapy as well, generally speaking. So, starting with what is immunotherapy? At its basis, immunotherapy is really just the process of your immune system naturally fighting cancer, or at least being activated in such a way that your natural immune system is actually able to fight off the cancer itself. And so this actually happens all the time without us even thinking about it. Cells in your body will naturally change, so sometimes there'll be a mutation or something like that, and your body will naturally kill it off. And this is all fine and good when everything goes right. But sometimes when cancer is able to develop, this is actually, what's actually happening is it's able to trick your immune system to hide from it. It's able to actually turn off the immune response. And immunotherapy is really the focus of how do you turn your immune system back on to notice those cells and actually be able to target them and actually affect a clinical response against it. And the overall field of immuno-oncology is really the study of this, the interaction between immune cells and cancer cells, and really understanding, what are the different immune cells involved, how do they actually interact with these immune cells, with these cancer cells, and what are the different drugs and ways that we're able to turn this immune response back on so that your body is able to do what it's naturally programmed to do in order to actually fight off the cancer by itself. And so really at the basis of all this, of course, is the immune system. Your immune system really does a lot of amazing things every single day without even thinking about it. You think about you're fighting a flu, this is fighting off a virus. If you get a cut and you get inflammation, it's because your immune system is helping ensure that you don't get an infection. But the same thing also happens when your body fights off cells that maybe have acquired some sort of mutation that could eventually turn into cancer. And really how this all happens is the interaction between those immune cells and the different things in your body, between maybe viruses or bacteria or other cells. And there's really an interaction. It's almost like a lock and key through something called antigens. These antigens are proteins or markers on the surface of your immune cells as well as on cancer cells and other cells that allow your immune system to say, hey, is this natural? Is this supposed to be here? And it's also able to say, hey, this is not supposed to be here. Let's get rid of it. And that's what we want to have happen. And that's really what the entire field of immuno-oncology is all about. It's basically recognizing that something is not supposed to be here and your immune system then kicking online and saying, all right, let's do something about this. So just as an overview, important term. Let's see. There we go. In terms of what immunotherapy actually does, there's a couple of different things that come into play. One is basically boosting the immune system. So when everything is good, you don't have an immune response going on. That is, you don't have inflammation going on. one of the aspects of immunotherapy is actually activating your immune system and actually just turning it on, saying, okay, let's go look for something. Let's get ready to fight. The second part of it is really marking the cancer cells, making sure that the immune cells get to where they need to go in order to fight the cancer cells or any other foreign body in the system. And this really comes down to, do they only target the cancer cells? Are they even able to get into the tumor? And so there's entire classes of drugs just dedicated to that. And then ultimately it comes down to, once you find it and once you have an activated immune cell, how do you actually kill the tumor cell? And there's a couple of different ways that this takes place. There's things like chemotherapy and radiation can actually be attached to antigens to specifically target the tumor cells in order to deliver the therapy right to where it needs to go with much fewer side effects than other traditional treatments. Then of course there's also the cells themselves. T cells are designed to basically kill any sort of cell or kill foreign substances that are not supposed to be there. And it really is a very targeted, natural process within your body. And so just thinking about, where does immunotherapy come into play compared to all of the other different treatments that are out there? When you kind of think about the cornerstones of cancer treatment, it's really surgery, radiation, chemotherapy. These really form the backbone of treatments that span all different types of cancer, from early stage, local cancer, all the way to much later cancer. And these work very well, and they're very effective, especially in earlier stage disease when they're maybe a little bit more localized. But when you start thinking about later stage disease, maybe stage 3 or stage 4, where you maybe have expansion into lymph nodes, or maybe there's metastasis that has occurred. This is where actually mounting a full body response is really something that's crucial. And so this is where immunotherapy is especially exciting, in that you're actually able to bring the fight to cancer anywhere in the body without necessarily just targeting one piece at a time and hoping that you get everything in one fell swoop. I just want to quickly pause and see if there are any questions from the audience. Yes, please.
All cancers like available for immunotherapy?
That's a very good question. We will touch on that briefly. The short answer is not right now. And there's clinical trials that happen all the time in order to try to basically expand the menu of cancers that are available for it.
Is stem cell therapy the same as immunotherapy?
It is similar. And that's kind of one of the starting points for stem cell therapy is, this comes down to basically reprogramming stem cells in order to fight the cancer cells. And it is sort of a class, and you especially see this when it comes to things like lymphoma and leukemia. And it's really when it comes to solid tumor cancers, where there's some new cutting edge non-stem cell based therapies coming out as well. Yes.
Are you finding that the stem cell source is making it more effective than another source?
That's a good question, and I think when it comes to efficacy, in terms of one drug being better than another drug, it's very difficult to tell right now, just because there's not necessarily these years worth of data yet. And so that's still, I think, an emerging question.
But you've got adipose fat, bone marrow, and another one.
Potentially, I think that there's a couple of different sources, and again, it depends on what type of cancer you're trying to fight.
So I see the targeted and immunotherapy are over. That's treatable only for stage 3 for the latter stages? So?
Exactly, and this is really focused on what is approved by the FDA. It's kind of the focus of this. Of course, in clinical trials, these things might move towards stage 1 and stage 2. But targeted therapies, these would be things like tyrosine kinase inhibitors, things like ALK and EGFR inhibitors that are a little bit newer on the market as well, but really are focused on targeting a specific type of cancer across your entire body that is already metastasized. Yes.
Okay. Hi. I wanted to ask about the small cell lung cancer I had. And there are no stages to that cancer. And it's an orphan cancer because there's only one protocol that exists. So in Israel, it's now tested immunotherapy to treat small cell lung cancer. Is it in the United States as well? It's rapid here.
That's a good question, and I know that there's continuously trials taking place, and there's always research in new cancers, but I don't know the exact guidelines around small cell lung cancer specifically in terms of immunotherapy right
That's a problem?
Yes, of course.
Okay, thank you.
And so just a little bit, just in terms of how is actually administered. This is generally an intravenous drug, and this is something, immunotherapy is a drug that's typically given at a physician's office. It's generally through titration. Ultimately, different immunotherapies have different dosing regimens. You'll have either different doses or possibly be given the immunotherapy in combination with other drugs, depending on what the approved indication is, depending on the cancer. And this can range from combining it with chemotherapy, and more recently there's been combinations with additional immunotherapies. So maybe you have one drug that helps promote the activation of the immune cells, and you have another one that helps promote the movement of the immune cells actually into the tumor site.
Is there any,
Yes.
Or
there
any
cancer problem that has been treated that you know of, or fact, by immunotherapy?
Absolutely. Absolutely. Well, that has been treated with immunotherapy?
Repeat the
Yeah.
question.
I think that the question is if there are cancers that have been treated with immunotherapy.
And been cured or something?
So,
Sure. So the most common cancers that are treated with immunotherapies today are non-small cell lung cancer. It's not curative, so to speak, but it's an advance on the existing standard of care. Melanoma is commonly treated with immunotherapies. There are a handful of hematological cancers, so leukemias and lymphomas, that are treated very well, and doctors start to talk about the curative potential for some of those blood cancers with immunotherapies, and you certainly see some patients, achieving complete responses and remissions. And so there are a handful of cancers that are being treated very well. There's not too much evidence of sort of curative potential, but there have been very good strides made and progress made compared to the existing treatments that were available prior to these immunotherapies.
So
How about breast cancer?
Breast cancer, there are some approvals in breast cancer for immunotherapies as well. It's very specific situations. So I think currently immunotherapies are only approved for triple negative breast cancers at a certain stage, and so it's not all breast cancers, but these are being explored broadly in many different types of cancers and tumor types within the clinical trial realm. So while they may not be readily available as the standard of care for many cancers, there are very many trials going on that are exploring the use of immunotherapies across many different cancer types.
I just got through with a year's worth of, I had stage 3 lung cancer, non-small cell, a year's worth of immunotherapy, and it cured, I'm cancer free now. Last week I found out. Yeah. Still very emotional. But I took a year of immunotherapy with this drug, and the cancer's gone at this moment. It can return, but I'm a success story.
Congratulations.
are immunos different between different people, or is it one immunotherapy could be used for everybody?
That's another excellent question. Certain types, the same drug is given to everybody. There's a class of immunotherapies called cell therapies, in which they take your specific cells and they make a specific therapy just for you. Those are typically the ones that are used in the blood cancers today, but they're being explored in other types of tumors as well. So it varies. Some are therapies that are made the same way and the same drug is given to everybody. Other types of immunotherapies are very personalized and based off of your own cells, for example.
You mean it doesn't matter what stage you are? Even stage 1 or 4 is the same?
In some cases. The question here is if the same therapy is given across all stages of cancer, and in some cases, yes. Later on in the presentation, we'll discuss some examples of different types of immunotherapies, and I can explain which ones are sort of standardized and are given across all different stages, and they're manufactured the same and given to everyone the same, and I can explain which ones are more personalized and might be used in different contexts.
And one additional point that Fanny will touch on in a short while is the factor of biomarkers. And every single cancer, even though it might be in the same spot, even though it might be non-small cell lung cancer or breast cancer, they're not necessarily all the same in terms of which markers are expressed that make them eligible for lung cancer. And that's where this whole field of precision medicine and immuno-oncology today really focuses on the diagnostics aspect as well, and actually understanding what is the biology of your cancer to make it eligible for one drug versus another. Yes, please.
Is there any chance that any or all of these immunotherapy methods is covered by insurance or some insurances, or certain selected ones only?
My understanding is that they are emerging as being covered as they are approved, and that's generally that's the process.
That's important.
Yes,
Absolutely.
yes.
And the immuno generally have zero side effects.
It's not fair to say that they have zero side effects. The research right now indicates that they have sometimes different side effects compared to traditional things like chemotherapy. But certainly there is evidence of that there are side effects that are active. So we will touch on that to some extent as well. Perfect.
Penny, are you going to ask a question about breast cancer of Israel?
Yes, please.
You know, last point says you can combine with other therapies,
Mhm.
immunotherapies.
Yes.
Did they combine immunotherapy with PARP inhibitor?
Yes, they do. That's a emerging field. I don't know if there's any approved indications for that, but that's certainly, especially when it comes to BRCA-positive cancers, BRCA positive cancers. That's certainly an emerging field of interest. Exactly.
How accessible is this, in different areas? Like, I live in Palm Springs.
Yeah. So access to the actual therapies. It's a very good question. The short answer is becoming more accessible, is my understanding. And this is possibly something that Fanny or Andrew could speak to, but it comes down to as it enters standard of care. So if something becomes a standard of care therapy, it will certainly be more accessible than something that is necessarily just in a clinical trial.
Yeah, I think one of the key things to consider is when all these drugs go through clinical trials to demonstrate safety and efficacy. And if they do demonstrate safety and efficacy, they can get approved by the FDA for use. The ones that are approved, they tend to get reimbursed, they tend to be widely available, all doctors will have access to it. And the approvals are for specific cancers. So it'll say this drug is approved for lung cancer, or this drug is approved for breast cancer, stage 3, for example. For situations where the drug's not approved for a particular type of cancer, it can still be accessible via a clinical trial, but it might be harder to access. It depends on where those trials are being operated. It may not be reimbursed in those particular situations by insurance, and so it's the accessibility and the ability to pay for them varies outside of the approved situations.
How you treat that with the injection, with the pills, and what is the side effect? Could you please tell the side effect?
Sure, I think we'll get to side effects in just a minute, but it's typically given through an injection directly into the bloodstream.
And there's no treatment in your offices, you're educational informative, right?
Correct, yeah, we are
How
not
are you
healthcare
teaching,
providers.
sharing the information with other oncologists and hospitals?
So we actually work with the companies that make therapies and make diagnostics. And so that's how we became familiar with this space. And so our job is to communicate between the drug manufacturers and the diagnostic manufacturers and help them understand how to get their products and services in the hands of doctors and how to get it to patients as best as possible.
Do you represent or work with any manufacturers?
Mm-hmm. Yes. We actually work with a lot of the companies that make immunotherapies.
Mm-hmm.
That's why we're familiar with this space.
Mm-hmm.
Are you going to talk about immunotherapy along with autoimmune diseases?
I don't know if it's covered in these materials. This might be mostly cancer focused. I know it's an area of exploration. I don't know of any approved, FDA approved uses of immunotherapy for autoimmune diseases, but there is an effort.
Not this, not here,
Sure.
but using immunotherapy.
Oh, and with sort of
I
a,
have lupus, and I'm also
that's an excellent question. I don't believe these materials cover that.
If immunotherapy can potentially be used to help treat autoimmune diseases as well.
Or to treat cancer for someone
Yes,
who has
yes,
an existing
yes,
autoimmune disease.
Yes. Yes.
So I don't believe that these materials get into that.
So just a couple of things to know, just like any other therapy, when it comes to immunotherapy, it's important to report any sort of side effects, whether expected or not, to your care team. As we touched on a little bit here, although there are absolutely promising results when it comes to immunotherapy, It does not necessarily work in every single patient. It does not necessarily work in every single cancer. And so this is something that's certainly an emerging field of discussion and an emerging field of research in order to understand who is best suited to receive these therapies compared to other standards of care that are on the market today. And then overall, related to this, there's still a lot that we don't know. And there's still a lot of research taking place in order to understand not only how to bring new therapies into the market, but really how to optimize and make sure that there's the most effective use of the tools that we have at our disposal today.
It would be just logical for the insurance companies to accommodate anything that has to do with immunotherapy, which doesn't cost them anything beyond just whatever is there without medications or anything, and having to worry about it.
Would you mind just repeating the question very quickly?
Immunotherapy for insurance companies should be really welcome and completely covered.
Yes. And I think that there's a lot of complex discussions taking place, especially since a lot of time these drugs come at a very expensive cost compared to standards of care. And so it is changing the discussions that insurers are having to have to some extent, especially when we start looking at some of the very customized therapies. These might be things called CAR T drugs, for example. These are your cell therapies, where they're tailor-made to the patient, where the cost is such that the insurance companies don't know how to accommodate that. And yes, there's absolutely discussions taking place in order to accommodate all of these classes of drugs, but there is still steps to be had before everything is covered. Just to quickly, before we move on to the next section, just a couple of the questions that kind of researchers think about today. Really, what is it about immunotherapy that works in some patients versus others? This is the concept of biomarkers. This is the concept of the actual tumor biology that makes a drug effective in one patient versus another. Ultimately, how can different immunotherapies be used in combination? How can they be used with chemotherapy? How can they be used with PARP inhibitors or with additional immuno-oncology drugs? Of course, when in a patient's course is it the best time to use immunotherapy? A lot of these therapies are not approved for first-line treatment. Oftentimes they come in at maybe second-line or third-line within an overall journey, but there is research underway in order to see, are these effective in a first-line setting as well? And then ultimately, what are the long-term side effects? And of course, this is an entirely new class of drugs, and there's still a lot of questions that are going to continue to be answered over the years as we understand really what is the lifelong, what's the long-term effect of these therapies. And so with that, I'm going to pass this over to Fanny.
Okay, can you hear me all right?
Thank you.
Perfect, just let me know if you'd like me to repeat anything. Great, so now I'm going to cover two sections here. Firstly, is immunotherapy right for me? And secondly, some of the side effects questions that we've already started to touch on. So as Colin mentioned, most people who receive immunotherapy have cancers that are advanced or later stage. Researchers have begun clinical trials to see if people who have earlier stage cancers may benefit from using immunotherapy as well. And as Colin mentioned, immunotherapy treatments are only approved for certain kinds of cancer at this time, or cancers with specific biomarkers, which I'll dive into on the next slide. And so if you don't have a cancer where an immunotherapy has already been approved, a clinical trial may be the only way to get that immunotherapy at this time. And your doctor in general can help you determine whether immunotherapy is right for you, if it's already approved for the type of cancer that you may have, or if there's a clinical trial that may be a good option to access the immunotherapy. So just to take a deeper look here at what are biomarkers, it's a term that we've talked about a little bit today and one that you may hear commonly now as treatments are becoming more targeted towards specific biomarkers, which are, at its best kind of broad definition, biological molecules found in tissues, blood, or other body fluids that may be used to determine if a patient is eligible for a specific treatment. So some immunotherapy treatments are approved for cancers with specific biomarkers. Examples of these are PD-L1 or MSI. So to give an example here, PD-L1 is a biomarker that indicates whether a tumor has initiated a counter response to the immune system. So that being said, it demonstrates whether your tumor has actually already tried to fight against the immune system. And PD-L1 indicates that a specific drug may be able to prevent that from happening. So it may be targeted by immunotherapies that can block its counter response. So I know that's a lot, but essentially, we have some diagrams coming later, but essentially in this example, the drug would be able to stop the tumor from sending away the immune cell and essentially stop the tumor from being able to disguise itself from the immune system. So that would alert the immune system that it should fight the tumor as a foreign body. Any questions on that front? Sure.
So wouldn't that be logical for all doctors? The first thing to try in any treatment is the immuno first, studying each person first for his immunotherapy abilities rather than going through different problems of drugs and so on?
Absolutely. So I think that's something that, as Colin mentioned, is being explored in clinical trials now. I think for earlier stages, oftentimes some of the existing standard of care treatments like surgery or radiation or chemotherapy may be still the best choice. But that being said, I think there's research going on now to see if immunotherapies may be viable in those earlier stages.
And oftentimes it depends on what biomarkers your tumor has. If you have certain markers, it might suggest that immunotherapies are the best first option. If you have other biomarkers, it might suggest that other therapies are the best first option. And so it's not considered a fact that immunotherapy is the best first option for every tumor type. It sometimes depends on that individual person's tumor, and there could be other treatments that are better first options.
But just my main concern is not having it easy for doctors to immediately result into all kinds of treatments and medications and so on that ultimately may not have been necessary if they first did a study of immunology first.
And that's exactly why doctors test for biomarkers, because they want to know, is there something about this particular tumor that can tell me what's the best therapy to use? So I don't have to use all these other therapies that might not be effective if I can know early on which one might be the best.
That means still they don't know yet for a sure, right? If they are just, exam now to see who's responsible, who's not. If we have to use as a mouse.
Sometimes there's considered what's the standard of care, and that's what's been proven over time and proven, via experience to work best in certain types of cancers. Other times it depends on that particular patient's tumor.
I think this question in the back. Yes.
How do you test for biomarkers? What is the procedure?
Yeah, absolutely. So you can either test, your doctor may do a test based on a tissue sample, a biopsy, or there's also tests that are emerging more and more that are blood-based or based on other body fluids like urine, for example.
But there's a term now, it's a relatively new term, it's called a companion diagnostic. This is a diagnostic test that you take in order to understand, is this drug right for you? And what it does is it looks for specific biomarkers that are associated with a specific drug in order to identify, are you eligible for this drug at all? It's called a companion diagnostic. It's a broad.
Is that like the liquid biopsy, the heme, the foundation one?
Exactly.
And how long is the return? I mean, if you're waiting, that's where I'm at. I'm waiting
Absolutely.
for the return.
Yeah, I think that varies test to test. I actually don't have an exact.
It can depend on the type of test that they're doing. Sometimes it can be, if they're doing the test at the local institution, it can be as quick as a few days. If they have to send it to a lab, you mentioned Foundation Medicine, or they actually mail the sample somewhere else, it typically takes 2 to 4 weeks.
That's the concern where I was just diagnosed with metastatic breast cancer. So it's, I have to wait, and I think time is of the essence.
Sure.
So.
question?
Yeah, very few hospitals are doing the testing for biomarkers, right? I know the city of Hope does, but LAC, USC, where I've been treated for 15 years, do they do that? I've had a lot of biopsies and tumors removed, so they have samples of everything that been removed.
They might be testing without, a lot of times the purpose for taking a biopsy is to send it to a lab to do biomarker testing.
Right,
So,
and
if you ever hear the clinicians say, we're going to send this to a lab, or, we're going to take a biopsy to run a test, oftentimes it's to test for a biomarker.
Do you have a name of a known lab that is really good at testing for biomarkers?
Oh, I had people.
There are a lot of different labs. So,
Or one that's like
there was a lab that was just brought up called Foundation Medicine.
Okay.
That's an example. I think a lot of the hospitals here will do biomarker testing. UCLA, USC, City of
like for
Hope.
prostate cancer, the Epstein lab at Johns Hopkins is number one.
Mhm.
So what is the number one for biomarker?
It depends on the marker. Just similar how that and that particular prostate lab is great for prostate. Different labs are good at different things.
So it's foundation testing.
It's one of them. There are a lot of other labs that will do just as good of biomarker testing.
Absolutely, and I would say that in terms of the turnaround time when to expect a result back, probably asking your doctor would be the best way if they have any sense. If they're familiar with working with a given lab, for example, you mentioned Foundation Medicine, they may have a sense for how quickly that lab gets the results back. And then, oh yeah, absolutely. Go ahead.
Just a question about the sequence of things. When a diagnosis is done with genetic matching of the tissue for a specific tumor, at that time, can they not do an analysis to see if the biomarker is present at the onset of diagnosis, so that moving forward, they'll know whether or not that biomarker is present to target it with an immunotherapy?
Absolutely. So I think at the time of diagnosis, as Andrew was mentioning, they may very well do biomarker testing. Whether that's clear at the time or not, I'm sure it varies. But I think that is a time where with the companion diagnostic test that Colin mentioned, where that will indicate whether or not you would be eligible for a certain treatment, they will oftentimes run that test at the time of diagnosis. But it very much, I think, depends on the stage of cancer, as we had mentioned, and the type. So it's sort of case by case.
If chemotherapy is started, will it alter biomarkers?
That's an active area of research. So that's something that doctors still don't know. Sometimes, in some cases, it's best to give chemotherapy before immunotherapy. Other times, it might be different, and that's what researchers are still trying to understand: is how do you sequence therapies the most effective way? Does it matter? If so, what's the best way to do it? So it's an active area of research today.
Does the cost of these tests influence whether or not doctors order the tests to begin with? And does insurance cover these tests for, let's say, biomarkers routinely, or is it a very complex process to get coverage or get insurance coverage to pay for these tests?
Great question. So the question's about getting insurance coverage for these types of tests that would look for biomarkers. And my understanding, and correct me if you have a different opinion here, is that if the companion diagnostic or other type of diagnostic test looks at treatments that are already approved for the type of cancer that you may have, in that case, it should be covered. I think if it's more exploratory, those are cases where a clinical trial would be a good way of having the type of testing and new access to new exploratory treatments that may be in research right now. And then other times, I think that would be a case where if it is more exploratory, but just looking at drugs that are already approved, but not necessarily for the specific type of cancer, that's an area where I think it could be more difficult to have the insurance company pay for the test. But I think it's certainly something that's becoming more common as new treatments are becoming available that are targeted towards biomarkers. So that probably depends on the type and stage of cancer, but would definitely be worth discussing if you're talking to your doctor about a diagnostic test that they may be doing, having the conversation right then of what does the insurance coverage typically look like for someone like me who's getting that test, for example, just to be sure. Great. So then one last point here on biomarkers. We wanted to communicate that biomarkers are also looked at for other types of treatments beside immunotherapy. So commonly in breast cancer, doctors may look at biomarkers such as HER2 or estrogen or progesterone receptors. And so these are just examples that may be more commonly known that are long-standing biomarkers that are looked at to guide treatment. So another example is a class of drugs that Colin has mentioned. These are tyrosine kinase inhibitors, and they target specific genetic mutations, such as ALK and EGFR. And targeting these mutations also shuts down key processes that are needed for the cancer cells to survive. So biomarkers and sort of this targeted approach to therapy isn't limited just to immunotherapy. But there are other types as well that will require biomarker testing and try to target specific mechanisms going on with the tumor cells. Great. And so what does it cost? So I think we already started to dabble in this here, and obviously it's a very important consideration. And so many new treatments, including immunotherapy, are very expensive. And cost will, unfortunately, likely be an issue for some or many patients. So I think, again, as I had just mentioned, talking to your doctor about what the insurance coverage typically looks like would definitely be a good place to start in terms of having that conversation, as these are kind of more general statements, and the situation will obviously vary patient to patient. But it is important to note that patients treated on clinical trials may have their drug costs covered completely, as well as the diagnostic testing costs that we had talked about. And so that's something that is really important to know in terms of if interested in a clinical trial or exploring that opportunity. This is a case where the drugs may very well be completely covered. So as I said, talk to your healthcare team up front about any financial issues, and they may have resources to help in terms of getting insurance coverage or some other types of patient assistance programs.
Are doctors usually or generally working for the patient or working for insurance companies and other drug providers? Unfortunately, some doctors may be tempted to use some of the drug companies and so on, unfortunately. What could be the defense on that? What could be the beginning talking about with the doctor, with the insurance company?
I would suggest talking initially with the doctor. My hope would be, and of course, there's many, many doctors out there, and this may not always be the case, but my hope would be the doctor usually has the patient's best interest in mind, and they're working with patients who have many different insurance companies. So they wouldn't be likely representing one specific insurance company, but it would be good to understand from the doctor's perspective, since they treat many different patients, what they expect to see in terms of insurance coverage. And I think, in terms of getting a second opinion or talking to other doctors, that could be also a good way if it seems the doctor is targeting one specific pharma company, or you're noticing something that leads you to believe, there may be a bias there. That could always be another way of just confirming it and seeking a second opinion. Great. So now to dive a little bit more into clinical trials, this is a point that we're talking about a lot today, given the fact that immunotherapies are still being researched quite a bit, and though there are approved therapies that are available, clinical trials are really active right now in the immunotherapy space. So it's great to ask your healthcare team about potential clinical trials. clinical trials are research studies, as Andrew mentioned, to test new treatments in terms of their safety and efficacy, and to learn how to use existing treatments better as well. So perhaps there's an opportunity to sequence the treatments, as we had talked about, between, for example, chemotherapy and then immunotherapy. And there's also several studies that are looking at combining different types of treatments together. So a clinical trial may be, at this time, the only way to get some of the newest, most promising treatments. And the US FDA and local review boards do oversee all clinical trials going on in the US to make sure they are conducted ethically with no unnecessary risk to the patient. And so, do we have a question? Sorry, yes.
Are you aware of any testing being done like the clinical trials about breast cancer, in which my friend tells me that in Israel now there is a treatment in which no mastectomy is required. It is by injection only, and that it will be here in the US next year. Next year is 3 weeks away. Do you know anything about that?
So I don't know about that particular treatment, but it's possible that something could be studied outside of the US and then brought here.
Sure.
Absolutely, yeah.
Do you know anything more?
They freeze it. They put an injection, they freeze it. You don't need a chemo, you don't need surgery, you don't need radiation. So compared with what they give out, I mean, why we have to go for this immunization that they don't know, and you have to go through all of this anyway. I want to know, for somebody like us that we already did the radiation, we did the chemo, we did the hormone therapy, still we need something like that?
And what was that last part, sorry?
I mean, if you know
if you've already had several
For
treatments.
the beginning, for the people they just got it, but for us that like I had it 5 years ago, cancer for breast, and I did a radiation, I did a surgery, and I am cancer free. I want to know, for somebody like us, still this is good to go through.
I understand. So the question was looking at breast cancer specifically around patients who may have had several different types of therapy already, and now there's a new treatment that it sounds like may be coming from Israel, and would you potentially qualify, or would other patients qualify? And so unfortunately, I'm not familiar with that specific treatment, but I will say that oftentimes immunotherapies are approved for patients who have had other treatments already. And there's newer treatments, I think, that would be coming out that would be looking at first line. So perhaps in that case, where it was the first type of treatment that they received. So I don't know details about the specific treatment you're mentioning, and if it would be something that folks who've already had treatment would be then eligible for down the line. But I think that bringing it up with your doctor, and if you found any information about that specific treatment online, they might be able to help understand if it would ever be relevant or for whom it's relevant. So I'm sorry, I don't know more details there, but.
Do you think they may eventually have a pill form of immunotherapy? Because I have a real rare cancer, and now they've given me all different type of chemotherapy regimens in the last 15 years, and now I'm on this pill form of chemo in a clinical trial. And I was just curious, maybe eventually.
I think they would if they could. I think they know
Maybe
people
someday.
prefer pills, and
Right.
they would, if they were able to do so, they would love to do so.
Gotcha.
I think it's something that they're probably actively trying to do.
And one of the complex things about immunotherapy, especially, is that it's actually living. They're oftentimes called biologics. So it's a very, I'm not going to say it's living, breathing, but it's certainly a very complicated molecule that does not necessarily interact well with your digestive system. And that's oftentimes why they put it directly into the bloodstream.
It looks like in the general case, in every unfortunate plague in the body, there is apparently a remedy of it somewhere else. Like just an example of a snake that has the venom at the same time of the poison. So it has in it the plague and the treatment at the same time. So that's what you call the immunology power which I would think that would be the first priority for any doctor. Should have the patience of looking at the patient first, immunological ability, rather than thinking of whatever is known or practical that may not be sure, and putting a patient through trials that might not really have to be necessary if he already has something that could help him, which means are all the doctors trained to be patient with their patients to find out first the natural immunology rather than coming up immediately with whatever may be known as.
I would say these days, every doctor is aware of immunotherapy and they consider it in cases where it would be relevant. There's been research and data to show that it just doesn't work in some cancer types, and so in those cancer types, a doctor is probably not going to consider it because they can point to evidence that it just doesn't work. So, while I think, conceptually it makes sense that it would be a very good first option, we have evidence to suggest that in certain cases it's not the best first option, and so I think the doctors, ideally are aware of the research and they have documents called guidelines where they can refer to what's the best practices and the standard of care, and they can typically determine whether or not immunotherapy is the best first thing to
Are
consider.
those guidelines available to patients or participants?
Versions of them are available.
There's a question right there.
Yes, can you explain in layman's terms the use of dexamethasone in infusions? I've had them, and unfortunately I have to start again. But I'm concerned about steroids. So what's the role of dexamethasone?
So, I don't know the exact context of this again. I know that there are some immunotherapies that are given alongside steroids in order to basically change. Steroids act on your immune system. And the purpose of steroids would be to create some change in the immune system to make your body potentially more receptive to immunotherapy or to help basically with the immunological aspect of the treatment. And that's kind of the broad context without going in, but I know that that's drugs that do things to augment your immune system are certainly seen as one of the key areas that are being explored for combination therapies today. Yes.
Great. And we will also go into, we have a couple of diagrams to help show kind of in layman's terms what's going on, but I think it's important to note to your question about immunotherapy being used immediately in all stages. I think that at this time, as we mentioned with biomarkers, a lot of the drugs that are available are targeting a specific mechanism that may not be in all types of cancer or in all patients. But that being said, I think that the research is trying to look at more inclusive biomarkers that could be targeted, that would cast a broader net to patients that could potentially get the therapies earlier, in earlier stages. So then the last point here is that participating in a randomized clinical trial means that you will receive the best available standard of care for your cancer or a new approach that may offer improved outcomes. So I think this lends to actually the next point at the top of this slide, which is that few patients actually receive a placebo or a sugar pill in a clinical trial. And you would be specifically told if this was a possibility for you. And so I think that's important to note when considering clinical trials, that you would either be in a group that was receiving standard of care, which may very rarely be a sugar pill or placebo. In the vast minority of cases that would happen. So you'd either get the standard of care or the new interventional treatment like an immunotherapy. So we just wanted to communicate that if you're not receiving the new immunotherapy, you're also still receiving what would be the standard of care that you'd normally get if you didn't choose to do the trial. Sure.
Why should somebody stay on the sugar?
That's a great question. So
And the
this.
second thing, wait, just a moment. I
Sure.
heard that with lethal malady, you don't, with cancer, you don't give placebo.
Absolutely. So the question was, just to quickly take this question, why would you ever want to be on a placebo, which is an extremely fair question. And I think that this is in a very rare cases. I've only seen maybe 1 or 2 clinical trials that have ever used a placebo. And this is typically in a very late stage of treatment where all other treatments have been exhausted. And therefore they're trying the immunotherapy almost as like that last line that could make a change for the patient. And unfortunately, in those very small number of cases, the alternative would be the placebo. So that's obviously an awful scenario. And that's why we want to communicate that it's very rare and that it will be specifically communicated to you as a possibility.
It's almost never the case these
Exactly.
days in a cancer clinical trial that the patient would be in a group that would be getting only a placebo. And so, and almost, I've looked at thousands of cancer clinical trials, and I can't recall really any in which one of the treatment arms is only a placebo.
In the discussion on clinical trials,
Mhm.
we had here last week, I believe, the doctors said no, that they don't do placebos.
Yeah.
Great.
What they do is either standard of care or the clinical trial. That it's not an option. There is no placebo.
And there's actually, there are laws that are trying to make that standard across almost multiple different disease types, even outside of cancer, that in clinical trials, patients shouldn't be receiving placebo.
Great. Yeah, so just to confirm that point, it sounds like recently it's been said that there will be no placebos used in clinical trials. So this was last medically reviewed earlier this year, and I think that's a mistake on this end. So I'm sorry to have communicated that, but it sounds like there's no chance of getting a placebo at this time.
So I just,
Yes.
a colleague or friend of mine,
Uh-huh.
Irvine, was in a trial that was exactly that.
Was it? Okay.
May or may not receive it, so.
Well, just to be clear on the way some trials, clinical trials are designed, you may be receiving standard of care along with an experimental therapy or standard of care by itself. So oftentimes they will give you the standard of care plus a placebo for the experimental therapy, but you will never, it's uncommon that you will ever receive only a placebo. They use the placebo to make it scientifically a scientifically sound experiment. And so you may still see if a doctor's telling you about a trial or if you're reading about a trial, you may still come across the word placebo, but in almost every case that's being used in addition to a standard of care.
Exactly. Yeah. Any other questions here? So I think that's a really important point to mention, that just to sum up, in a clinical trial, you'd either be receiving the standard of care or an interventional treatment.
But the doctor should take his time to find out, not to take an initial treatment that is not sure of if it's going to work or not, when he can try the first early part.
Absolutely. And so I think that doctors will be able to provide a good perspective on if a clinical trial is the best decision, because if there's a better treatment that already exists that you can be 100% sure that you will be getting, rather than having it be the potential of standard of care or the new treatment, I think the doctors will likely suggest to continue with what's already available and not explore a clinical trial at that time. But that being said, if the trial is looking at a standard of care that's similar to what you might also be getting without the trial, I don't know if that makes sense, but yeah. So in that case, the doctor may suggest a trial because worst case scenario, you'd be getting the normal treatment that you get without the trial. So they'll be able to kind of walk through what makes the most sense.
They are working for more cents or dollars.
If they don't know side effect,
Great. So a few other points on clinical trials here. You can leave a clinical trial at any time and get standard treatment from your doctor. So you're by no means locked in to that obligation. And every doctor does not have the same trials. So you may have to change doctors to join a trial and potentially go to an academic center, which commonly have like a hospital associated with a university commonly have clinical trials, although I know there's a lot of efforts to diversify those clinical trial opportunities across all the different kind of settings of care besides the top universities, for example. So that's a discussion that your doctor will be able to facilitate in terms of where the trials might be taking place. And then, exactly, so often the trial pays the cost of the drug being studied. And then your health insurance and copay would cover a standard treatment cost. So again, be sure to ask your doctor what costs you may incur.
There are literally, on clinical trials, few patients receive a placebo. Do they not have to give 50% of the patients in the trial? So that's a huge number.
Good question.
A huge chance of being on a sugar pill.
Absolutely. So to clarify this point, this is around the idea that 50% or half of the patients on a clinical trial would be receiving the interventional treatment, and the other half would be receiving the standard of care. And so the word placebo, I think, at least from my understanding, has often been misused in that sense, where it actually is what you would normally get outside of a trial. The standard of care could be chemotherapy, radiation, surgery, and so on. So what we're communicating here, and it sounds like this point is actually potentially incorrect or something that's changing, is that there are very few trials, like maybe I've seen one in the past that has used a true placebo rather than the standard of care. And that's an effort that it sounds like from other medical professionals that have come and spoken here, as well as what Andrew was mentioning, is no longer occurring in new trials that are coming online. So you're absolutely correct that in every trial, about half the patients will not get the intervention, but that means that they're getting the normal standard of care, not a placebo. So I think that's a very important point. So definitely let me know if you have other questions about that.
Or placebo, and the bottom line is that the distracting mind of the patient, so-called, it is not a medication, it's not a treatment, it's not a remedy, but it's something to distract them in the meantime. Or what?
No, so
placebo, is it a drug?
Yeah, so I think
might not have side effects.
Great question. So I think what we've determined is that placebos are not being used, but in this normal standard of care that half the patients would be receiving, the reason that not all patients would get the interventional treatment is because they have to prove the safety and efficacy of that new treatment relative to what's normally considered the best option.
So an example would be if there's a trial that's comparing a combination of 2 drugs versus a combination of 3 drugs. If a patient receives 3 drugs, they know which treatment they're getting. And the way to do trials best is to make it so that it's blinded to everybody. That's how you make it scientifically, experimentally sound. And so in the 2 drug combination, they will give a third pill, which is basically a sugar pill, so you can't tell the difference between who's getting what until later.
So somebody gets sugar pills, they don't get diabetes?
What was that? It's not always a sugar pill. It's usually just an inert, some sort of
Good question. Yeah. So definitely important to just clarify the point here, which is that in clinical trials, if you're not getting the new interventional treatment that's being explored, you will be getting the standard of care that you would otherwise get if you did not choose to be on the trial. So that's something that I think there has been a lot of kind of like misconception and probably misuse of the word placebo, like I kind of did earlier. It sounds like there's being efforts to actually remove that from ever being a case where you wouldn't get the standard of care. Great. So any other questions here?
I just want to thank you for being articulate all over, for shifting your information and for monitoring your mic up. So it was really
Yeah, well, I think it's an important point, and I've done quite a bit of research in our company to speak with cancer patients from across the U.S. and Europe on behalf of drug and diagnostics manufacturers that are interested in understanding the patient perspective. And something I've seen is that there's a lot of miscommunication around clinical trials. So I definitely want to clarify those points. And it's something that's difficult to understand because of the different possibilities and so forth. But it's good to know that you would at least be getting the treatment that you would normally get outside of a trial if you chose to join.
How does the patient find you? I mean, other than once they know your name, they can look you up. If they don't know you exist, I mean, I think it's marvelous that all of you in your company have found this organization and that you are prepared and continuing to learn more every day, probably, and doing a wonderful service for the world, really. So,
Well, we're glad
it's
to be here.
hugely
So you
important.
have it on a screen somewhere that everybody can copy.
No, we're really happy to have the opportunity to come. So
I hope you go to the other locations for the, don't worry about them, they know.
come give us tips after.
They know how to get the people.
Great, so now to look at side effects from immunotherapy. We had already mentioned that the side effects for immunotherapy can be quite different from typical side effects of, say, chemotherapy. And often people might think immunotherapy means sort of natural treatment, but even this sort of natural treatment in terms of using drugs to target your natural immune function do have side effects. So many of these side effects that we typically see are manageable and mild, but they can be serious. So it's important to always let your healthcare team know whenever you do develop a new side effect.
So if the company still doesn't know what is the side effect, after the treatment, after you use the people, then you find the side effect, and some people.
Absolutely.
That's
Yes. So the point is a very fair one, which is that sometimes, though there's these sort of common side effects that patients usually experience, there could be new side effects given that these treatments are fairly new compared to something like chemotherapy that's been around for a long time and has more established side effects. For immunotherapies that are being approved more recently, it's definitely fair to say that there could be out of the norm or new side effects that you experience. There's some listed here that are sort of less common side effects on the bottom of the slide. But that's why I think it's definitely important to talk to your doctor if there's any side effects that arise, especially if they may come outside of the normal list. Here. Yeah. So some common side effects could include flu-like symptoms, fatigue, sometimes rashes, and so forth here. And then some of the less common side effects could be gastrointestinal problems, thyroid problems, and lung problems. So we aren't medical professionals, any of us, but I think that
Yes, you are.
well, we're very knowledgeable about the medical field and specifically about immunotherapies, but we're not ourselves physicians by any means. So I would say this is something that we know about at a high level, but definitely I would encourage having conversations with your doctor to understand what side effects are to be expected, as well as making sure that you have good communication about new side effects that may occur.
But would you be qualified to be called immunologist so that you can refer to a doctor? I mean, my immunologist told me.
Unfortunately, I don't have an advanced degree in immunology, but great. And then there are also possible long-term side effects. So this is important to note here. Research shows that it could cause the immune system to attack healthy organs. I think this is in rare cases and something that's still being looked into. But we just have to mention it here out of fairness and transparency that it could cause some of these more severe side effects. But this is definitely rarer from what we know of the drugs that are currently available. So again, something I would defer to your doctor to talk about and understand what those side effects and risks could be.
Can you speak about why those side effects happen?
One more time, sorry?
Can you speak about why these side effects happen? If
Why the side effects happen?
is targeting a specific target, why do these things happen?
Yeah, so it's an area of active research, but anytime you administer a drug, even if you're targeting a marker that's that's specific to the tumor, that marker is often used in the body to do other things. And so there, we can some of the biomarkers that were mentioned earlier, PD-L1 is a common marker for immunotherapies. It's expressed highly on tumor tissue. It's also expressed on other tissues. And so if you target PD-L1 to disrupt the tumor, it's going to interact with its natural function in the body. And I think disrupting sort of the natural function of some of these drug targets is what leads to side effects.
Exactly. When you think about overall what immunotherapy is doing, it's trying to activate your immune system. And an activated immune system is what you see in cases like autoimmune disease, for example. It's an overabundance of inflammation. And that's really what the implication is. If you have too much activation of your immune system and it's not only targeted towards the cancer, you can have these instances where you have inflammation in other parts of your body, and that's what causes some of these effects.
I want to know if this have that much side effect and somebody want to make the immunization higher, why we don't go in a natural way that we don't have any side effect, then we go through that we don't know, what's going to happen to us. Because we have enough problem ourselves. We want to make it less. We don't want to make it more. And I'm so against the drug, any drug, even the, Advil or placebo or whatever, because I know every drug, including even vitamin, have a side effect. So if we can go naturally, why anybody want to attend for this to make it herself more sick?
It's a very good question, and it comes down to that is one of the biggest areas of focus when it comes to using these drugs today, is how do you make them only target the cancer without targeting anything else? And it certainly is not desired. And it's the unfortunate side effect of having something that is biologically active in your body, is it acts on a lot of different things. And so that's absolutely something that with biomarkers and with testing and with very in-depth discussions with your clinician, it's important to understand, what is the payoff between the possible side effects and the benefit that this drug can potentially give, and how do you actually manage those side effects?
But you're not sure about the benefit yet. So that means you don't know what's use of it in a benefit, or you know more about side effects. So that means you saw something about those things that you said is a side effect, right? But you didn't see anything about to be better treatment.
Well, to be clear, this doesn't happen to everybody. Some people may experience side effects, some people may not, and so just like some people may respond to the treatment, some people may not. It's sort of a balance of the benefit and the potential side effects.
Are there any proven cases where immunotherapy has contributed to the death of someone?
No.
And it was a death because of immunotherapy, not because of other reasons?
That's a good question. It's hard for me to think of specific instances.
I've heard of stem cell therapy causing someone.
I know sometimes in cell-based therapies, sometimes the side effects can be severe if they're not managed properly. But I can't think of too many specific cases off the top of my head. But it is something. That's why it's important to notify clinicians immediately, because oftentimes side effects can be managed relatively simply, and you don't want side effects to propagate and get worse because it can lead to more severe.
So there's no lawsuits out there, class action lawsuits against immunotherapy companies.
There may be.
Is there any modern studies finally to identify the previous treatments of drugs that might not have been working, to take them, identify them, and see if they could be treated immunologically rather than having to have used those drugs, and therefore eliminate those drugs?
Absolutely, and a lot of cancer types for which immunotherapies weren't being used before, research are studying, do immunotherapies work in these cancer types, and if so, can we make immunotherapy the standard of care compared to chemotherapy or what was used previously? So that's actively ongoing across pretty much all cancer types. People are looking to see, are immunotherapies effective in this cancer type?
These are for cancers that are refractory to effective treatment.
That, as well as cancers that haven't been treated yet with anything. So you can in a lot of clinical trials, even for standard of care, you can receive an immunotherapy as your first treatment, depending on what type of cancer you have, or it could be a second or a third line treatment refractory to other treatments.
Great. So this is our last slide here in terms of talking about side effects. So just to go over briefly some actions that you can take, I would say the top point here is in terms of talking to your doctor to learn about possible side effects before you begin the treatment, and even when potentially having a conversation about different treatment options to make sure you understand what to expect. Because obviously side effects are very important and can affect quality of life and so forth. So it's important to evaluate what those side effects might look like before starting treatment if possible. And then, as I said, this third point, make sure to let your doctor or nurse know immediately if you do experience any side effects. And if identified, serious symptoms may require treatment as well. But as Andrew mentioned, we already covered this, the second point, everyone reacts differently to treatment, so being prepared is important, and also communicating that experience with your doctor is important.
What kind of pharmaceutical is making that? What company?
You said what type of companies are making the drugs?
Yeah.
There are many different companies that are making these drugs now. So many different options.
Dozens, if not hundreds, of companies are making some form of immunotherapies.
Mm-hmm.
They're gonna get rich soon.
Yeah, so the immunotherapies are not coming from like one pharmaceutical company that's saying all of this. It's definitely coming from a bunch of different groups. Sure.
Yeah. Is there any research on studying this in preventing cancer?
Great question. So the question is about if there's research into using immunotherapies to actually prevent cancer rather than treat it. Do you know it, Andrew?
I don't know if I've come across any concrete research being done using immunotherapies to prevent cancer. Where we see a lot of effort is doing screening to catch cancer early so that it can be treated surgically as opposed to with some sort of systemic therapy. And so there's a lot of energy and effort today studying how do you detect cancer as early as possible so you can remove it with surgery when the treatment rates and the success rates are higher than when it develops into a later stage disease. So there's a lot of effort there, but I haven't seen too much research on using immunotherapies as a preventative tool.
Great question. So now we have a few slides that will dive into the different types of immunotherapy, and there are actually several classes of drugs here. So I just wanted to pause here before we move on and get into sort of the weeds of some of the specific drugs to make time for any questions you have at this time, and if not, we can keep moving forward. Mm-hmm.
What type of immunotherapy is used with the PARP inhibitor? Or they're experimenting?
They are experimenting, and generally it's a class of therapy called checkpoint inhibitors. So the first one.
Great, here.
While he's doing that, what is BCG for bladder cancer?
So BCG is specifically, it is a type of bacteria. It's almost like a vaccination. And it's inserted into the bladder in order to create an immune response so that your immune response is heightened.
People do when they're in treatment?
Yes, it's usually following surgical treatment.
Question?
And I've had around an immunotherapy last year, and I just found out I have to go for another round. Which one of these relates to multiple myeloma?
There are a few. I know that there are checkpoint inhibitors related to multiple myeloma. I believe there are T-cell therapies related to multiple myeloma. But a lot of these different types of therapies are going to be used across a lot of different types of cancers, or at least explored across multiple different types of cancers. And in the interest of time, I'll try to work through this quickly so we can get through as much material as possible. And a lot of this is fairly detailed, and so if you do have access to the materials, it's good to just have it handy as opposed to trying to keep up with all the information on the slides that I shared. But I think one thing that's important to consider is we've been talking a lot about immunotherapies, but it's important to know that immunotherapy consists of a lot of different types of treatments. It's not just one type of drug. There are different treatments that act in different ways. Different types of treatments are used in different cancer types, and so someone who's getting an immunotherapy for one type of cancer might not be getting the same type of treatment as someone who's getting an immunotherapy for a different type of cancer, but they all still have the same underlying mechanism of using the immune system to attack the cancer or to treat the tumor. So the first is checkpoint inhibitors. This is a very popular class of immunotherapy today. If you've seen commercials on TV for Opdivo or Keytruda, and when we talk about PD-L1, it's referring to this class of drug. And very briefly, the immune system has safeguards or checkpoints which are put in place to prevent it from attacking healthy cells. So oftentimes if you have inflammation, you don't want the immune system attacking your normal tissues, and so your normal tissues have a safeguard against inflammation. And these are checkpoints. And so to avoid being killed by the immune system, some cancers are able to sort of co-opt this checkpoint mechanism to basically hide itself from the immune system. And so what often happens in some tumors is that the immune system will start attacking the tumor. The tumor will then express these checkpoints to hide from the immune system so that the immune system can no longer attack it. And so the objective of these checkpoint inhibitors is to basically allow the immune system to re-recognize the cancer.
That's really important.
It is. And so this is exactly the mechanism that happens. And I'll explain this. I'm a scientist, so I like to explain diagrams like this. But if this is the tumor cell, and you have a T cell, this is the immune system attacking the tumor. And usually that happens when the T cell receptor recognizes something, a specific molecule in the tumor called an antigen. Now, what happens is if the tumor cell expresses a marker called PD-L1, and the T cell happens to recognize that, then it will turn off the T cell. The T cell won't attack the tumor. And so that's how it hides from the immune system. So the checkpoint inhibitors work by preventing that interaction from happening. They prevent the tumor cell and the T cell from having that PD-L1 interaction, and that allows the T cell to continue its sort of tumor killing activity. And so this is what we call a checkpoint inhibitor. And so there are various types of checkpoints. PD-L1 is just an example of one of them, but there are various types of checkpoints, or checkpoint inhibitors rather. Some of them interact with the tumor itself, some of them interact with the T cells, but they all serve the same function, which is essentially to stimulate the T cells to better attack the tumor. And so this is a very popular class of immunotherapy today.
Is that what attracts? The PD attracts the PD-1, whatever it is, attracts it to come to you to be killed, or it goes straight into the...
So the T cells, they're constantly being attracted to the tumor, actually via the tumor antigen. That's what brings the T cell to the tumor. And when it gets there, if the tumor happens to be expressing this PD-L1, the T cell is going to get turned off. And so scientists are trying to prevent this PD-L1 interaction so that the T cell doesn't get turned off. And so you've heard us mention this quite a bit, but an important class of checkpoint inhibitors refer to this PD-1, PD-L1 pathway. It's a very common pathway that's being explored. As I mentioned, the interaction of PD-1 and PD-L1 sends a stop signal to the immune system. And so there are various drugs and therapies that are being explored to prevent that. And here's a list of some of them here. I won't read through all of them, but these are actually all approved therapies, and they're each approved in different types of cancers. And we can look through a list of those.
What's the difference in the mechanisms of this?
So the difference is some of them bind to this on the tumor cell to try to disrupt that interaction. Some of them bind to this on the T cell to disrupt the interaction. So both effectively disrupt the interaction. Some companies just take different approaches into how they want to disrupt it.
The side effects the same?
Largely. They're largely considered similar. We've talked to oncologists who consider them almost interchangeable in terms of whether the drug targets the PD-1 or the PD-L1. But they have largely similar efficacy and safety profiles. And so here's a list of different types of cancers that these are being used in, and you can see that it's a broad list, and there are many more different types of cancers that these drugs are being explored in. It's very common for drug companies and researchers, once they find a class of therapies that seems to work well, they want to see if it works well in everything. And so these drugs actually only really, let's go back here. These drugs have only really been around for the past 5 or 6 years. And so this is a relatively new class of treatment, these checkpoint inhibitors. And so there's active research underway to determine what types of cancers do these work best in. I won't go through these slides in too much detail. These are just the names of some of the different PD-1, PD-L1 inhibitors. There's one called avelumab or Bavencio. This is a PD-L1 inhibitor. It's being used to treat Merkel cell carcinoma and bladder cancer. Again, all of this is as of January 2018, at least in this case. And so some of this there may be new approvals for some of these drugs. It's important to talk to your care team. There's a drug called pembrolizumab or Keytruda. This is approved in a larger variety of cancer types. There's one called nivolumab. You may have seen, there are a lot of commercials for this one on TV.
Previous slide.
Oh, sorry. So, going the wrong way here, sorry.
So quite often doctors are not familiar with all these things.
What was that, sorry?
Doctors are not familiar with all these possibilities rather than going straight into drugs.
Very often they are. Oftentimes a doctor who treats one of these types of cancers will be aware of the latest treatments and the latest therapies that are available to those types of cancers. There are conferences every year that are tumor specific. As I mentioned, there are documents called guidelines that get updated regularly so that when there's new data about new drugs for treating different types of cancers, that is made available to doctors. Another PD-L1 inhibitor is atezolizumab or Tecentriq. This is approved in bladder cancer, non-small cell lung cancer, small cell lung cancer, and in some instances for triple-negative breast cancer. Durvalumab is another one. It's also approved in non-small cell lung cancer as well as locally advanced or metastatic bladder cancer. And Libtayo is a PD-1 inhibitor, and it's approved in cutaneous squamous cell carcinoma. And so as you can see, there's a lot of different types of these therapies, and they're used in different instances for different conditions. Another checkpoint, different from the PD-1 or PD-L1, but another checkpoint marker is called CTLA-4. And this is actually expressed on the T cells, and this is just a different mechanism for stimulating the T cells to kill the tumor. And so there are certain drugs that target the CTLA-4 marker to try to stimulate the immune response. And so this is just another mechanism of doing essentially the same thing. And there's a drug called ipilimumab or Yervoy that targets CTLA-4. And this is approved in melanoma, colorectal cancer, and kidney cancer. One thing I should clarify is that a lot of the different approvals that I've been showing are based off of what the FDA has said the drug is approved for. These are also being used in sort of an experimental setting in clinical trials for other types of cancers. And so there's possibilities that these drugs will be accessible for different types of cancers that aren't shown on this list in clinical trials. We talked a little bit about combination therapies. People are exploring combining immunotherapies together to get some sort of synergistic response or looking to see if it's better than using two together than one by itself. A common combination therapy is looking at CTLA-4 and PD-1 together. And so that's something that's actively underway, and there are indications, or there are certain cancer types where this combination of drugs is approved. And another thing to consider is that there are a lot of different immunotherapies other than these checkpoint inhibitors. And so the next few slides are going to focus on other classes of immunotherapies that don't fall into that checkpoint inhibitor category. And so there are other molecules called monoclonal antibodies, and these are, as Colin was mentioning, fairly complex molecules that recognize a specific protein in the body. And typically, drug companies or researchers try to design these antibodies to recognize a cancer-specific protein, and by binding to that cancer-specific protein, it disrupts the cancer pathway. And so that's the strategy behind these monoclonal antibodies. Not all of them are immunotherapies. There are some that don't have an immune-related mechanisms, and there are some that do. Here's a list of a handful of monoclonal antibodies that do have an immune mechanism, and so they'd be categorized as immunotherapies. As you can see, they're used fairly broadly in hematological malignancies and blood cancers. They tend to target molecules that are expressed on immune cells, or T cells. Here is a continuation of that list as well. Are there any questions so far about any of the therapy classes that we've discussed?
Is this along the lines of East-West medicine?
No.
In which the East would use mostly the natural remedies and plants, whatever it is, to enforce the natural rather than having to resort to drugs.
No, the decision on which particular drug to use just depends on the type of cancer you have and some of the biomarkers that we discussed earlier. There's a lot of inputs into the decision on which is the best drug to use, and that's what you typically would talk to your doctor about, and that's why you provide sort of the biopsies and all the information so that they can choose which of these is best.
Before you go on to the next slide, can you comment a little further, or any of you, on the daratumumab, and certainly in combination with the dexamethasone that I was asking about. Why would they add that?
It's not my specific area of expertise. I don't know if I have any specifics I can provide on that.
Do you?
I don't. Sorry.
It would be something that your doctor would probably be able to provide more information on. Sorry.
So, excuse me, these are targeting T cells?
Not exclusively. They target multiple different types of cells. It depends. Sometimes B cells, sometimes T cells, different types of immune cells. But they target these particular markers, the CD markers, which tend to have some sort of cancer-related function. And so the idea is that by binding to these markers, you can sort of disrupt that cancer-related pathway.
And a lot of these actually are also, they're specifically antibody-drug conjugates. And what that basically means is it has chemotherapy attached to a tumor marker.
Yeah. Question?
Yeah, you asked if we had any questions on any other groups
Mm-hmm.
of cancer. So, I haven't heard once verbally or seen anything on the screen about pancreatic cancer.
Mm.
Do you know anything about that?
I know it's an active area of exploration. I don't know if any of the sort of therapies that we'll be discussing today are approved in pancreatic. I think this is actually sort of the end of the therapies list. I don't know, Colin, if you have any insights on pancreatic cancer.
Not specifically related to directly immunotherapy, but there's exploration in pancreatic cancer for BRCA, so BRCA, as it's oftentimes known. So there's exploration of using PARP inhibitors.
I thought BRCA was for breast.
But it is actually implicated in a number of other cancers as well, and this is why it's an exploration area. So there's clinical trials underway, specifically in pancreatic cancer, in patients who have BRCA mutations for the treatment of that disease.
Is there any interaction?
These are combination therapies. For instance, the rituximab, is that a combination of chemo plus immunotherapy? Is it a complex?
So Rituxan is oftentimes given as a combo, so it really just depends on what your subtype is.
So it's just a component of the combination, but the drug itself, rituximab itself, is not.
CD20 inhibitor. Exactly.
Could the colonoscopy not, when it's not practiced, could be really one of the causes for the pancreatic cancer?
Colonoscopy?
If, if one doesn't follow seriously the colonoscopy treatment regularly in 5 years or whatever it is, wouldn't that be more preventive to have the future pancreatic problem?
We know it's certainly used to try to catch colon cancer early. The goal is to use it as a screening tool to catch colon cancer early. I don't know of any research done to indicate whether or not it would be used to catch pancreatic cancer early.
Usually it has to be abdominal ultrasounds are typically used for pancreatic cancer.
We talked a little bit about cell therapies, and this is a very, very new area of research and where you can basically engineer or program a cell to identify or attack a specific tumor. Sometimes if the immune cells in your body don't do that very well, researchers can actually take them out of the body, program them in such a way that when they get put back in, they can identify and attack a tumor. And so this is a very active area of research. You might have heard about CAR Ts or CAR-based cell therapies. That refers to cell therapies that are specifically engineered, taking cells out of your own body and then put back in to attack the cancer. There are some approved CAR T-based cell therapies, specifically in some blood cancers, so in advanced leukemias and lymphomas, and actually as well as in pediatric populations for those cancers.
So the cells are genetically altered?
Mm-hmm. Yeah, they're genetically altered to express a protein that recognizes the tumor, specifically. Cytokines, you might hear about cytokines. These are molecules, proteins that are used to stimulate the immune system. It can speed up the growth of T cells and activate a number of other aspects of the immune system. And so they might commonly be used in combination with other therapies to provide a boost to the immune system to sort of jumpstart it. They've been used for many, many years, and they've had the sort of resurgence as a potential tool alongside some of these newer immunotherapies. Some examples are interleukin-2 or interferons. And there's also various vaccine-related approaches to immunotherapy. As I'm sure everyone's aware, vaccines are used to oftentimes to create an immune protection mechanism against viruses and other sort of infectious diseases and pathogens. But they can also be used to provide a response against cancer. If you think about cancer as a foreign body, something that's not natural, you can create a vaccine against it to boost the immune system to the presence of that cancer. One example of a vaccine that's used as an immunotherapy is called Provenge. It's used in advanced prostate cancer. It's, I guess, the only approved vaccine by the FDA today to treat prostate cancer. But there are many other vaccines under research for other different cancer types. We talked a little bit about BCG, as Colin was mentioning. It's actually a bacteria that's used in bladder cancer. And it has a similar effect of once it gets into the bladder, it allows the immune system to better recognize that bladder cancer. I don't know if that's my mic. That sounds better. Are there any questions about any of the therapies? I know I went through it pretty quickly. If you have access to the materials, I encourage you to keep that as a reference, but I'm happy to answer any questions I might be able to answer before we move on.
The treatment that you mentioned for prostate cancer, the vaccine,
yes,
can it be used as a preventive?
Not that I'm aware of. Again, I think that's an area of research that I think is still fairly nascent in terms of trying to prevent cancer altogether. It would be hard to run those types of experiments. Those would have to be carried out over a very long period of time. And so I think a lot of researchers focus their energies on treating cancer or detecting it as early as possible. But it's certainly, with an area that would be valid for research. It's an interesting question, certainly.
Because the other ones, the hepatitis B and the HPV can be used preventively.
Exactly. If you think about sort of the nature of vaccines, the idea is that it's more of a preventative measure, and so it seems like you should be able to apply that to cancer as well. And so I'm sure that there are people that are thinking about this.
Are these treatments being used with children as much as adults?
Not as commonly, and when you do a clinical trial for a treatment in children, you have to do it specifically on children, and so some of them are. We talked a little bit about adoptive T cell therapies, and there are some of these T cell therapies that are being used in children, and they work very well, and so there are many companies that are examining immunotherapies in both adult and in pediatric populations, but it does require that you do the research differently. You can't just do research in adults and assume that it's going to behave the same in children and vice versa. And so it requires, very different studies.
I noticed one of the slides had 12 years old and old.
Yeah.
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 That's one.
Exactly.
Is this the same thing, or does stem cell transplant fall under this category?
Stem cell transplant would be a little bit different. So stem cell, to my knowledge, stem cells when they're transplanted aren't genetically altered. They're taken and they're taken from a donor or someone, and they're put into a patient sort of in their natural form. These cell therapies are a little different in that they're specifically genetically altered. So researchers will actually, they have ways of going about and changing the DNA of the cells to make them express a specific marker, and then once they've shown that they can do that, they put it back into the patient. And so it's a little different in the sense that most stem cell transplants, you're not necessarily altering the genetic makeup of the stem cells.
It's all new aspects of creating more medications to enforce the immunology therapy. In an example for this, encouraging one cell to kill the other and the other one to prevent it and so on.
Mm-hmm.
So there's another list, all of it, of new medications that have to be created that are already there, besides whatever the other medications of not immunotherapy require.
So I don't know if I fully understood the question, but these are all generally very new therapies.
Right.
And so, this is, as I mentioned, these cell therapies as well as the checkpoint inhibitors that I mentioned. Some of these immunotherapies have been around for a while, but the checkpoint inhibitors and the cell therapies, this is something that's really come on the scene in the past 5, maybe 10 years. And so it's relatively new, and so researchers are still trying to understand the best ways to use it, And so it's I know it's a very exciting area of research. I go to cancer conferences and these immunotherapies are discussed very regularly and commonly at cancer conferences. And so you're right, it's almost an entirely new class of therapies that's being developed, from the ground up in some cases. So
I don't think I saw a slide or heard you mention anything about brain tumors. Is immunotherapy being looked at for brain tumors?
It is. Brain tumors are challenging just due to the blood-brain barrier and getting drugs across that, and so they are being explored. I don't know, Colin, are you aware of any approvals in glioblastomas or brain tumors?
I'm not, and typically the treatments that are seeing the most research right now in brain tumors are targeted therapies, so they're actually still trying to target a specific mutation as opposed to activating an immune response. And another component of it is there's not a tremendous immune population naturally living in your brain compared to the rest of your body. Just given that it basically has the blood-brain barrier, you're not able to get recruitment of immune cells as readily in your brain compared to other places. And it all comes down to immune activation ultimately in making these therapies work.
So if you target them, like it's next to the brain and the primary tumor is in the lungs, and you target the lungs, then that should have continuous effect towards the nuts as well in the brain.
Potentially, and that's, certainly, again, the brain cancer has been not the largest area of study to date, but certainly as these drugs are show efficacy in more and more therapies, we are seeing different approaches with them in new cancers like the brain, including glioblastoma, for example.
We have time for one more question.
That was it.
You had mentioned materials. Were there materials available?
Perhaps you may.
So we ran out of what materials we had. Just to remind you guys, this is gonna be up within a month and the slides are all available on the videos. So there'll be a link on our website. It's all on our YouTube page. Okay, so even if you didn't get the handouts, they match this exactly.
What's the website?
Our website is on all of our materials. I'll give it to you after. Yep, and then it's just the link up.
Did you finish all your slides?
I believe there's a handful of additional slides. I don't know time-wise what we have.
The remaining slides are a couple here on quality of life that it's not specific to immunotherapy, but just touching on this in terms of resources that are accessible. So I believe those are materials that you might be able to
Are you
distribute.
going to say anything about the companion tests?
In a particular context, I think we discussed a little bit when it came to biomarkers that there are tests called companion diagnostics where they look for a specific biomarker that's associated with a specific drug. And so in that case, you might get what's called a companion test or a companion diagnostic for that particular biomarker. And if it's found that your tumor expresses that biomarker, or if you have that biomarker, then you might be eligible for that drug. But oftentimes, if you don't have that particular biomarker, then that drug's not a good option for you. And so that's in the circumstance when there's a drug that targets a very specific biomarker, and Herceptin is an example of that. Herceptin is used in instances when the patient has what's called HER2 positive breast cancer. And if you don't have HER2 positive, you're not likely going to be eligible for Herceptin because Herceptin specifically targets HER2. Great. Well, thank you all. Oh, was there another question?
Yeah. So if you have prostate cancer and you're looking at BRCA2 and you have a BRCA2 of undetermined significance, is there are there specific biomarkers for that?
Do you have a sense on this?
So what's interesting, what you're touching on is a very important kind of discussion that a lot of oncologists are having today about instead of classifying the tumor by its location, classifying it by the biomarkers that are present, which in turn will indicate which drugs are likely to be effective or not. And so in the instance, I don't off the top of my head know if there are approvals for the use of BRCA for guiding treatment in prostate cancer. But that is the sort of thing that if there, for example, is a trial where they're looking at treating that, they would absolutely test to see what the BRCA status is in order to try to enroll patients in that trial.
So is there a specific BRCA test as opposed to the Garden 360, which is tests 100 genes?
There are lots of BRCA tests. Just to name a couple, Myriad has a test. Foundation Medicine, I believe, has a test for that. There's quite a few. A lot of these, you might have heard of Quest Diagnostics before. They test for everything. It's a very common test these days. It's looking for, at this point, a well-characterized mutation that a lot of labs are able to run. It's just well characterized. It's well known. So a lot of labs are able to run this test these days. But those are just a couple of the brand names, even though there's a lot of equivalent tests available, even in hospitals.
Well, thank you all for your time. We really appreciate it.